So, good afternoon. It's about time to have an exciting 1-hour debate. And it's a pleasure for me to open up this session together with my co-chair, Lisa Pickering, and fantastic faculty, actually. Before we really start the session, there's just a little announcement that basically the John Fitzpatrick Award lecture will be following directly after this session. So there won't be an interval in between. There won't be a break. It will be directly after this session, not as it is being disclosed in the program. So keep this in mind and stay in here. Okay, so I do have a few slides for you in order to really bring you up to speed, I think, a bit. I put in some colors to make it more joyful. I think it's an exciting time for kidney cancer treatment because we really embarked on not so effective therapies with cytokines. I mean, some of you may still remember those times. And then we started off with single agent targeted therapies, and nowadays it's combinations. It's all about combinations. And when we speak about the different efficacy parameters, I mean, they're depicted here. You can just pick your favorite choice, basically. But I think what is more important is really that we really bring down those combinations that are most appropriate for a single patient. And I mean, these are 3 different patient cases. As you may see, they have different problems, So, and I think that's something that is important, and it's also the luxury in kidney cancer that we can really select the best or most appropriate treatment for the problems of our patients. And in order to do this exercise, we have really exciting faculty that will do a very good job, I think, to discuss the role of triplets. I think that's what Tien will do. TKI-IO doublets, that's what Laurence will speak about. And for Mike, I don't know. I mean, it's IO-IO. Surprise, huh? Yeah, it's IO-IO. And Kate will discuss toxicity management, and then basically Lisa will round it up with cases in order to make it more digestible. Okay, so with that having said, I think it's time to really start the debate. And Tien, you're on. I mean, you're on the spot. Triplets.
All right. Good afternoon, everyone. Thank you so much, Victor, for that kind introduction. And I'm really happy to be part of this debate and talking about IO-TKI triplets today. So we'll talk about first-line treatments in metastatic kidney cancer and then discuss some of the promise and dreams of triplets. So as Dr. Goingwell just showed us, we have a plethora of new treatments in kidney cancer. Many of these treatments are targeting the angiogenic axis, and we now have multiple therapies that block the VEGF receptor, as well as HIF-2 alpha, which we'll talk about more tomorrow. But very importantly, kidney cancer, clear cell kidney cancer, depends on angiogenesis, and we have multiple drugs to target this mechanism. Immune checkpoint inhibition also has changed what we do in kidney cancer and improved our outcomes for patients with metastatic kidney cancer, both from CTLA-4 blockade as well as PD-1, PD-L1 blockade. In this particular schema, IPI, Nivo, and pembrolizumab have all been approved for kidney cancer. So I want to take us first through the first-line doublet trials, which I know Dr. Albigez will talk more about, but these are the old first-line trials, if you will. So these were all patients with clear cell kidney cancer with measurable metastatic disease, randomized and stratified by IMDC criteria as well as region of the world to either a control cohort of Sutent alone or the immunotherapy-based combination. So we had 6 trials, phase 3 trials that have been done in this space, all with similar designs compared against sunitinib. I won't go into the details here, but everyone was treated until disease progression or unacceptable toxicities, and primary endpoints were generally around progression-free survival survival and overall survival. And what we know, and what I'm sure Dr. Albiges will be telling us, is that these immunotherapy doublet combinations have changed our treatments and are available and improved our overall survival for patients with metastatic kidney cancer. So I concede that point. Of note, however, the progression-free survival intervals that you see here, Checkmate 214 did not show a PFS difference early on, but what we did see is that the VEGF-IO combinations with KEYNOTE-426, axitinib, pembrolizumab, Checkmate 9ER with cabozantinib and nivolumab, and CLEAR with lenvatinib, pembrolizumab have all improved progression-free survival intervals. So what are these next generation first-line trials look like? Well, similar patient cohorts, but the control cohort is now immunotherapy-based combinations. And now we have multiple treatments with trials ongoing in the frontline setting. And the first trial to read out was COSMIC-313, reported at ESMO last year, the combination of ipilimumab, nivolumab, and cabozantinib compared against ipilimumab, nivolumab, IO doublet. So this is a terrible faux pas. Do not try this at home. But I've melded two Kaplan-Meier curves together to try to show what the rationale is in combining triplets in early disease settings. So what we would like to do is to mold the progression-free survival of VEGF-IO TKI IO combination with early disease control, with early progression-free survival benefit, with a prolonged progression-free survival interval and the durability of an IO doublet. So we've combined the curves of Checkmate 9ER with cabozantinib, nivolumab, with the PFS curve of ipi-nivo with a durable, long-lasting PFS delay. And so prolonged progression-free survival time, and also we would like to improve the complete response rate of these treatments. And so that was the premise of combining these triplets in COSMIC-313. So these are the baseline characteristics. Many of you have seen this data presented at ESMO about 6 months ago. What I would point out of this 850 plus patient population randomized is that of note, 75% of them had intermediate risk disease, 25% poor risk disease, and then the 65% prior nephrectomy cohort. These patients, more of them had de novo metastatic disease than in prior doublet IO and IO-TKI trials. And these are the primary endpoint of progression-free survival that COSMIC-313 was built around. For the intention to treat population in the primary analysis, progression-free survival was improved, has a ratio here of 0.73, which was statistically significant. Now, if you build that out in the progression-free survival of intermediate risk versus poor risk disease, what we see is that, unfortunately, what we were hoping to see was that in both populations, PFS would be improved. But what we're seeing is PFS in the poor risk disease is now crossing over, and technically the triplet is not better than IO ipi-nivo in this setting. And so this has us all scratching our heads a little bit in that, potentially, why is this the poor risk patient population doing worse? And of note, what we do see, however, is the disease control rate is quite high in both cabo-nivo-ipi treated patients as well as nivo-ipi treated patients, 86% disease control rate. However, the complete responders were only 3% in each cohort. And that, I think, what we were hoping with the triplet was underperformed than the rates that we were expecting of 10% or higher. And you'll see the waterfall plots below. Of note, I would point out that the complications and toxicities of the triplet has much higher grade 3-4 events of elevated transaminases, hypertension, which we expect of the VEGF TKI portion, and also lipase and amylase increases. Dr. Pauls presented this data at GU ASCO just 2 months ago. These are median and duration of exposures of treatment for patients treated with cabozantinib. You'll see that median durations of exposure as well as the median average daily doses are very similar across the intermediate and poor risk populations. The 4 doses that Vipi received was actually higher in patients with poor risk disease. About 70% of them received all 4 cycles of ipilimumab. And then when we look at dose holds due to any adverse events, very similar compared against populations. And so median durations of these of exposure and daily doses are similar, but I would counter that these patient populations are biologically different, and so perhaps a poor risk patient population, even though these medians are similar, some of these patients couldn't afford treatment breaks. So don't take my word about the triplets. Dr. Albiges, who's our counterpart on IO-TKI doublets here, will tell you all about how awesome IO-TKIs are, but she actually says, so more follow-up is needed, but clearly COSMIC-313 is a positive trial in frontline setting, potentially changing the landscape. That's my boxing gloves for the day. So my thoughts on COSMIC-313 and triplets. This was a positive trial that improved the primary endpoint for progression-free survival. We do need to await overall survival data. And these medians don't drive the Kaplan-Meier curves. I think patients do, and every patient that lives longer or has longer progression-free survival intervals will lengthen out these curves longer. And so I do think intermediate risk and poor risk disease are biologically different, and so therefore we're seeing some differences in how these triplets are playing out across populations. And we do still need to improve treatments for the next patient who comes in and balancing that toxicity with efficacy. I am a bit biased, and there are 2 ongoing trials that we have open at UT Southwestern and across the country with both Pedigree, which is an adaptive phase 3 design of ipi-nivo followed by randomization to nivo or nivo-cabo, and other triplet trials in the frontline. LIGHTSPARK-012 is open. It's a randomization of lenvatinib, pembrolizumab as the VEGF-IO doublet compared against belzutifan, lenvatinib, and pembrolizumab versus lenvatinib, quemliclustat, and pembrolizumab. And that trial is also ongoing and enrolling globally. So in the final minute, I'll just remind everyone that multiple immunotherapy doublets have changed our frontline standard of care for first-line metastatic kidney cancer. The first triplet of cabozantinib, ipilimumab, and nivolumab did improve progression-free survival compared to ipi-nivo, and other triplets are on the horizon, perhaps with sequencing or with new promising triplets in ongoing trials. And with that, I'll conclude, and thank you so much to the KCA for having us talk today. Thanks.
Thank you very much, Chan, for that illuminating talk. So now, while you're all considering whether you are persuaded about the use of IO-TKI triplets, we look forward to seeing what Dr. Laurence Albiges has to say to argue against that, and as we've seen, slightly argue against herself as well. Laurence.
Thank you, Lisa. Well, first, I would like to thank the KCA for the invitation, and especially to be part of this lively debate. So first, I would like to stress we do know that combination of IO plus VEGF-TKI is standard of care. And there are actually at least seven arguments for that. The first one is what the guideline says. So it's a no-brainer for a favorable IMDC risk group. And with regard to intermediate and poor, what the guidelines tells us is 3 times VEGF-TKI plus IO is standard of care. So where does that come from? Well, the rationale is that we do want to be able to use both of our mechanism of action that has demonstrated benefit as single agent therapy. There is also a rationale that these are potentially synergic, meaning that you may enhance the immune response by allowing immune trafficking thanks to your VEGF inhibitor. It also allows us to cover the spectrum of all the different subtypes that has been identified, from your VEGF angiogenic-driven tumors to your immune-infiltrate tumors. And ultimately, also help, we've seen this morning very nice pathological slides to address the intratumoral heterogeneity that we may see within one patient. Now, third aspect that is key to our patient is efficacy. And what we do know with early or so-called early endpoint, as David McDermott would say, is that we are doing a better job with a TKI in the combination with regard to duration of your progression-free survival, but especially with regard to your response rate. 6 to 7 of your patient out of 10 will have significant tumor shrinkage. It is also the fact that you will not see upfront progressive disease. Taking LenPem, for example, less than 5% of your patient may experience PDS-based response. And this is extremely important in a symptomatic patient, for instance. This is a clear difference when compared to an IO-IO strategy, for instance. With regard to complete remission, I like to say that 1 patient out of 10 will have complete response with IO-IO. This is what I've seen in my clinic. Well, now when I look at the numbers with more follow-up of the IO-TKI combination, I feel it's pretty much the same, and this is what the data are telling us. We see that also in our IO-TKI regimen. So the sheer dogma in favor of IO-IO is a bit out to me. Ultimately, what we want is long-term survival. And here again, if you pull together those trials, you end up seeing that the hazard ratio for overall survival are clearly in the same ballpark when compared to sunitinib. But it's unfair to mix good risk and intermediate and poor. So I'm going to split them. And what we do know is not only looking at median, but especially looking at hazard ratio for overall survival. Here again, TKI-IO perform actually as well, even better than IO-IO, for which we had this strong signal earlier on because we had the results earlier and we had more follow-up. But with more and more follow-up, this is something that we are seeing with IO-TKI regimen, namely nivolumab, cabozantinib, for instance. I know that Mike is going to touch on good risk IMDC patient. In Europe, we may not use IO-IO regimen. But here, I think it is important to stress that there is a rationale for not having approval, at least in Europe. When you look at the numbers for PFS, almost more than 2 times higher in favor of VEGF-driven strategy, as well as for response rate, almost 2 times higher. So that is the rationale. And also this morning, we had the comment from Gabrielle on the fact that those tumors may be VEGF-driven, and therefore we need a VEGF inhibitor in those patients. So once again, good risk patients should be treated with IO-TKI. Now, I was touching on the fact that with more follow-up with IO-TKI regimen, we are now seeing consistent hazard ratio, and these are the recent data that were presented during ASCO GU with the 9ER study. Nivolumab plus cabozantinib, starting to see a plateau here, and a very stable hazard ratio of 0.7. One comment will be safety. Well, you know how to handle VEGF-TKI toxicity, you know how to handle PD-1 inhibition toxicity. So we know those toxicities. It's mostly driven on the daily basis on the VEGF-TKI, so therefore we know how to manage that. This is what we've done during lunch break with Nizar Tanir in your Meet Your Expert session. How do we manage toxicity? By dose reducing our VEGF-TKI. There's very few overlapping toxicity, and in this case, I turn out to our chair. We have guidelines. We'll hear more from Kate later on how to manage the few overlapping toxicity, especially GI and liver. This is something we've learned to manage over the past years. One concern is about, let's say, more rare but acute IO-IO-driven toxicity. And this is not the 214 cohort, this is the 914 cohort, so it's adjuvant. But what I want to stress here is that those agents, especially when we add CTLA-4, may expose our patient to life-lasting toxicity. And if you think 1 patient out of 10 will be in CR, this is significant, or life-threatening toxicity. We don't know yet the added value of the CTLA-4 exactly in the toxicity. We know that from our clinic. Maybe the 8x8 study that I'm co-chairing with Dr. Atkins will answer the question of the added toxicity of ipilimumab. But what we do know for our clinic is that we need to carefully monitor those patients because we may expose them to acute and long-lasting toxicity. The 5th argument, and we heard from Tian, is that IO-TKI is now standard of care, and we know that because this is what we need to outperform in the new trials. This is the O10 study, also addressing the question of triplets, Well, len-pem is the comparator, as to my point, one of the most efficient comparator active combination we have nowadays. Outside of clear cell, where do we stand? Well, there is still a role for IO-TKI. These are the Keynote B61 data that have been presented last ESMO, will be presented at ASCO, clearly showing a great role of a potent VEGF-TKI plus PD-1 outside of clear cell RCC. Where we may end up and saying that we agree on in today's debate is that until we have a biomarker implementation, it's hard to select. And this is a trial that just got funded through both charity but mostly EU funding that will be launching in Europe this summer, where we actually have a head-to-head comparison of IO-IO and IO-TKI to close our debate today. As Dr. Atkins pointed out earlier this morning, there is a rationale to see an enhanced immune response in PD-L1 positive patients. And here, these are actually two superiority trials with the hypothesis that in PD-L1 positive patients, IO-IO will outperform IO-TKI. But that's the subset of those patients that are PD-L1 positive. So my take-home message are the following. First, IO-TKI is the standard of care across all RCC in frontline, given the strong activity we see in early endpoint, and also the long sustained benefit in terms of overall survival. Second, IO-TKI is the standard of care that we need to overcome in our future trial. And to Tian's comment, overall survival is the endpoint that we need to beat. And PFS is not enough from our physician perspective, but also from the patient perspective. Thank you very much.
Laurence, thank you so much for that. And so for those, I'm assuming everyone has been paying attention today, you'll understand there was only one person we could really ask to face the plethora of IO-TKI data. And so I'm delighted that Mike Atkins has agreed to share his experience and knowledge about the IO-IO combination with us. Thank you, Mike.
Yeah, thank you very much. And going third, I have to follow those great arguments that presented by my colleagues for their therapy, so we'll see if I can make a case for IO-IO. And my learning objectives will be that curative therapy is possible in patients with advanced kidney cancer, and in order to enhance the chance for cure, the best pure IO therapy needs to be given first. So here are the PFS curves for the CheckMate 214 for the intent to treat group, the intermediate and poor risk group, and the favorable risk group. And you'll see one of the features of immune therapy, in contrast to what you see with sunitinib, is a tail on the PFS curve that is clearly present in the ITT and the intermediate and poor risk, and may be developing in the favorable risk population. And that's particularly true in the sarcomatoid population. You saw the overall survival curves presented earlier today. This is the PFS curves for patients with sarcomatoid kidney cancer, where you have a tail that's above 50% now. In the PFS curve, 60% overall response, 19% CR, compared to sunitinib, where the PFS curve hits the x-axis. But the real feature of immune therapy, pure immune therapy, is the duration of the response. So let's hear the duration of response curves for the 214 study, and we can see in intermediate and poor and favorable risk, and in everybody, there is this tail on the duration of response curves, and median duration of response has not been hit for any subset. And taking that into consideration, we can also see that for the complete responders in this data here, there were 58 of them in the trial. 51 of them were still having an ongoing complete response. And in looking at these swimmers plots, where you can see the blue area, you can see that many of those patients are having a complete response that's ongoing despite having stopped therapy. And I would argue the group in the top who's still on therapy is being overtreated. And even some of the patients in the bottom switch therapies without ever progressing. and 61% overall of the partial responders are continuing to respond. So what that means with immune therapy, IO, is that you can have, in addition to all the other efficacy endpoints, you can see treatment-free survival benefit, as I talked about this morning. Here it is for the intermediate and poor risk compared to sunitinib. Of the 60 months, 10 months are spent free of treatment on average. And even in the favorable risk population, you can see compared to sunitinib, there's 3 times the treatment-free survival benefit in the IO. So the rationale given for combining IO with VEGF therapies is been repeated overall in this particular slide, where there's promotion of T-cell priming and activation of dendritic cell maturation. There's normalization of tumor vasculature for increased T-cell infiltration, and there's establishing an immune-permissive tumor microenvironment for decreasing MDSC and Treg population. So this is true. This is all good data in preclinical models, but there is no appropriate preclinical model for a VHL null immune competent tumor. And that, what I'm hoping to show you both in preclinical models and in patients, that this is not what happens in patients. In the preclinical models, when you give a TKI to a patient, and this is arterial spin-labeled MRIs, which are perfusion MRIs, this is not patients, this is mouse models, you can see that 3 days in, you lose all the perfusion in the tumor. You essentially infarct the tumor. You lose all the blood vessels. And then if you keep treating this mouse, by 9 days out, you're starting to see angiogenic escape with this rim of perfusion developing as the tumor is becoming resistant to the TKIs. And by day 22 in this model, and in other models it takes longer, more representative of what happens in patients, you can see the perfusion is back to baseline. But what is happening when you see that angiogenic escape? You are seeing, in contrast to what was said on that rationale, you are seeing an influx of myeloid-derived suppressor cells, which are driving that angiogenic escape. And so I would argue that this is not the optimal time to try to activate the immune response, which countless amounts of data show is best activated in a highly oxygenated, a non-hypoxic immune microenvironment. And I think we can see that in the shape of the PFS curves. I've already shown you the 214 data, but if you look at the Cabo-Nivo data comparing to sunitinib, there is not a tail there. The shape of that curve is exactly paralleling the shape of the sunitinib curve. It just moved a little bit to the right because there's some little bit of the immune therapy that's there. And although my colleagues will talk about no PFS benefit for the IO combination early on, you can see those curves overlap. I can say that all of those patients can still get cabozantinib or some other TKI, and we know from the Cabo Point trial that a patient who has intermediate risk and got IO as their first-line therapy can get a nice response, 40%, Dr. Albaji's data, with just Cabo in the second line. And these are all the PFS curves for all the IO trials, IO TKI trials with Ipi-Nivo as well. And I point out that Ipi-Nivo has a tail. These others are all falling. And all these patients are TKI naive, and there's no data on treatment-free survival on these patients. So these patients, as far as we know, are going to be on treatment for the rest of their lives. So we don't have the data we need. I'm glad you're going to be able to do that trial. Laurence, in Europe, we couldn't convince the US cooperative groups to compare IO to IO-TKI. But we do have data from melanoma, which I'm have been involved in, and which is, I think, a few years ahead of what we're going to see in kidney cancer. And this is the DREAMseq trial that I led, which randomized patients to either nivo-ipi followed by dabrafenib, trametinib versus the converse sequence. And what we can see here, that although the dabrafenib, trametinib did better in overall survival early on, the curves eventually cross, and there's this 20% difference in overall survival at the 2-year time point, and by 3 years, that difference is out to 25%. And then we've also tried to combine TKIs with IOs, what we call our own triplet regimens in melanoma. And these are all the triplet regimens. This is PFS, and there's really no tail here. And if you look at the DREAMseq data at 2 years from just the IO component, you can see that 40% PFS is already above what we're seeing for the triplets in melanoma. And if you look at the 067 data, which looked at ipi-nivo in the BRAF mutant population, you can see at 5 years it's 38%, and that looks like it's at least equal, if not better, than what we see from these triplets at 2 years. And the patients who are progressing on ipi-nivo still can get BRAF MEK inhibitors. And so the lessons we've learned from melanoma is that nivo-ipi followed by TKI is associated with the greater landmark overall survival than the converse sequence. This is true because nivo-ipi results in more durable responses and TFS than TKI in the front line, and that TKI works as well in the second line as it did in the first line, as we see in Cabo Point compared to Cabo Sun. And while IO doesn't do that, as we see comparing the frontline data from the Hoosier trial to Checkmate 205. And also that IO-TKI combinations are less effective for overall survival in TFS than the approaches given in sequence. So the principle for melanoma is to maximize overall survival or cure, you need to give the best IO followed by the best non-IO if necessary. So here's data in favorable risk. This is from Tom Powell's, looking at all the hazard ratios for all the doublets. And although this yellow triangle shows that nivo-ipi is bad early overall survival hazard ratio, not sure why that is, as I mentioned before. By the time you get out to 4 or 5 years, nivo-ipi is the only combination in patients with favorable risk that has a hazard ratio less than 1. So just like in melanoma, these curves are crossing. And here's the COSMIC 313 data that Tien showed. And in the poor risk patients, the curves are crossing. In the intermediate risk patients, they're staying apart, but those patients can still get Cabo. And so when you think about IO, non-IO combinations, I think it's I have to keep in mind that IO is different than tumor-directed therapy because of the ability to produce treatment-free survival or cure, and that combinations that improve PFS or median OS without producing TFS may sacrifice the potential of IO while contributing extra toxicity, extra inconvenience for longer time on therapy, and tremendous extra cost or financial toxicity. And therefore, I look at these things and I say that not only must A plus B be better than A2B or B followed by A, but I want to see TFS or cure maintained in order for me to endorse those agents. And clinical trials with IO agents should use IO endpoints, not median PFS. And those are landmark PFS, overall survival, landmark overall survival, and TFS. So when it comes to first-line treatment choices for advanced kidney cancer, I'm going to risk sounding like this famous Gary Larson Far Side cartoon regarding equine medicine, where no matter what the problem is, the treatment is the same. For patients with sarcomatoid histology, because of amazing efficacy and poorly responsive to TKIs, I'd give them nivo/ipi. For patients with poor risk, because of better PFS and CR rate than in the triplet Cosmic 313, I'd give them nivo/ipi. For patients with intermediate risk, I recognize the PFS curves are lower for ipi/nivo than with the triplet and probably for some of the doublets early on. But ipi/nivo is less toxic, TFS is possible, and when people can still benefit from salvage, full-dose cabo, and overall survival and quality of life will likely be better, and we haven't seen those results. So I would give those patients nivo/ipi. And for patients with favorable risk, it's the only doublet with an overall survival hazard ratio less than 1. Extensive TFS is possible. All with progressive disease are probably doing well and can get a salvage TKI, and the HCR and favorable risk data suggests that immune therapy may work better than we thought, and so I either give them nivo/ipi or a PD-1 monotherapy. And so my take-home messages are, our goal should not be simply to turn kidney cancer into a chronic disease. We should strive to make kidney cancer a curable disease, and to do so using combinations at the first-line treatment that maximize the anti-tumor immune response is really critical to achieving that goal. So thank you very much.
Mike, thank you. It felt to me like the take-home message was nivo/ipi, full stop. So now that Mike and Laurence and Tian have treated your patients very effectively, I hope, very carefully and very skillfully, I'm sure, they may have given them durable, lifelong, or serious toxicities. So I'm delighted to welcome Dr. Kate Young, who's my consultant colleague at the Royal Marsden. And not only is Kate a consultant medical oncologist, she's also the acute oncology lead for the Royal Marsden, and is our go-to person for treatment-related toxicity. Kate, thank you.
Thanks, Lisa. So thank you very much for the organising committee and, of course, the KCA for inviting me to speak today. After that lively debate, I have the slightly easier task, I would say, of talking a little bit about optimal toxicity management in this setting. So the learning objectives today are how we can think about selecting our patients to really think about who we put forward for these different regimens to try and reduce toxicity, how we can know what toxicities to anticipate, and how we can educate our patients and their families and other healthcare professionals to do that as well. Some top tips for how to manage these toxicities when they occur. So this actually is a significant problem, and whilst in sort of medical oncology speak we would say that these regimens are well tolerated and there were no unexpected safety signals, if you look across these percentages, these are high percentages of patients getting treatment-related adverse events. So for example, looking across that third row down, I would just flag that the clear data, that's actually for just adverse events rather than treatment-related adverse events, which is why it's a little bit higher. But these are significant percentages. And of course, there are also significant percentages of our patients having to stop treatment because of these adverse events. And these are trial patients. These are performance status 1 patients. These are not the people we see in clinic. And we've also heard from a number of the excellent talks earlier on today that our patients are not telling us about all their toxicity, and we're probably not asking the right questions anyway to get the toxicity information. So this really could be the tip of the iceberg. So this makes it super important that we very carefully select the right patients for these regimens. Of course, this is a big balance. There are factors related to a patient's cancer. That we've talked about the IMDC risk group, and obviously there are pros and cons of that, and future genomic and transcriptomic groups perhaps. Sarcomatoid histology, whether somebody needs a rapid response. But there is a lot of other factors that we need to consider carefully as well regarding somebody's comorbidity, their cardiovascular risks. Have they got a propensity to autoimmune conditions? Do they suffer from chronic viral infections? Have they had a transplant? Are they elderly with multiple other medications that they're taking? And we very much want to approach this, I think, as a community, that this is an individual case-by-case discussion through MDT, through support from all of our different colleagues about what the right approach is. So having selected the regimen, I think, don't worry, I'm not going to talk through all of these again. there's a lot of data out there. I think we have a good idea of what to anticipate. And we need to make sure that we are asking our patients about this in a supportive way again. So I think trying to let patients know that actually telling us early about toxicity may be able to keep them on treatment rather than people worrying that telling us what's happening is going to make us take them off. As well as knowing what we might expect, there are various guidelines and other data out there that can tell us when we might expect particular toxicities. So for example, thinking about our checkpoint inhibitors, we know that skin toxicity is often earlier than, say, nephritis or something like that. I would say all of this I would very much take with a pinch of salt, because certainly, as Lisa said, in our acute oncology experience, we've had patients rock up with very early toxicity from immune checkpoint inhibitors that wouldn't necessarily fit these patterns. So a high index of suspicion is always useful. So as well as the healthcare professionals knowing about what to anticipate, we need to make sure our patients are really well educated alongside their families as to what might be going to happen to them on these treatments. And as well as our patients and their families, the other healthcare professionals that our patients go to before they might get to us, so the doctors in A&E, the GPs, everybody needs to have 24/7 sources of advice for what to do with these people, because these aren't easy things to manage necessarily. So there's lots of creative use of hotlines, many guidelines, teaching sessions, and of course all our patient advocacy groups have a huge role to play here. I think there's probably a lot more we can do in this space as well. So there are interesting trials like this CAPRI trial, relatively recently presented. It's a French trial of over 500 patients on oral SACT, including over 60 patients with kidney cancer. And this was looking at either standard follow-up, where just the oncologist asked about symptoms, versus enhanced follow-up, where there was an app, there was a nurse-led phone clinic, etc. And it really interestingly found that those patients with the additional support had better outcomes. So not overall survival, but better outcomes in their experience, less treatment-related adverse events grade 3, fewer hospital admissions, and really importantly, actually had a higher treatment intensity. So that stopping early, pausing, perhaps having a dose reduction, meant they went on and had more treatment. And I think that's a really important message for our patients. So coming on to management, I think we're all getting much more familiar, particularly in this community, with how to manage our IO-IO combinations. Of course, we've had to completely relearn how to manage toxicity. This is very different to chemotherapy or TKIs, completely novel spectrum of adverse events. These are all a result of a highly activated, completely unconstrained immune system, and really anything can happen. Any organ can be involved, and that high index of suspicion is so important. So, top tips from acute oncology. As I've said, be suspicious, investigate. If you're worried about somebody, or they're saying, if the patient's flagging anything, just do take it seriously and investigate. Once you've found one, look for others, and also consider multiple causes. So that person who comes in with diarrhea, is that a colitis? Is it thyroiditis? What's causing this? Fatigue is something that as oncologists, we're used to our patients being tired through the cancer itself, through the treatments that we're familiar with. But with IO-IO, there are lots of actual serious causes for fatigue, and having a good fatigue panel is really important. Don't forget about the IO treatment when you've moved on to second-line TKIs, because basically you're almost giving triplet treatment in doing that. And we know that some of our IO toxicity can be exacerbated by TKI treatments like colitis. Most IRAs don't settle without steroids, but if the steroids aren't working, we do need to think about moving over to our other immunosuppression, biologics, etc. early, rather than just going with really high doses of steroids. And it's important to involve interested ologists. So I think we're really lucky that across the world, more and more of our cardiology colleagues, gastroenterology colleagues are developing specialist interests here, and particularly in these cases that are difficult to manage, they have a wealth of experience we can draw on, and I think working together with them is really important. Be careful when you're taking somebody off steroids. They often have flares. And of course, when you're stopping steroids when somebody's been on them for a long time, do think about hypoadrenalism, whether people need a cortisol or a short synactin test to check that they haven't got lazy adrenal glands by what we've done to them. And also make sure people are on supportive therapy on their steroids. This is an evidence-free area, so we are basing what we're doing based on what our ologist colleagues have done with autoimmune conditions. And whilst that's a good basis for this, and we know that this works in many cases, there may well be much better ways of doing this, steroid-sparing ways, and these are difficult trials to run. So if anybody in your area is running trials in this space, please do get involved and help with that. Coming on to managing either IO-TKI doublets or in the triplet setting, obviously this picture is more complicated. And whilst, again, my colleagues have said that we know how to manage these things. Sometimes there are those patients in clinic in front of you with diarrhea, with hepatitis, with hypothyroidism, with a bit of dysphonia, slight cough and shortness of breath, and we just don't know, is it the TKI, is it the IO? I think the timing of the toxicity can be instructive. Knowing the half-lives of our drugs is something that I definitely rely on in clinic quite frequently. If in doubt, stop both drugs, see what happens after a few days. If the patient's relatively well, you've got a bit of time, you're monitoring them closely, that can be the easiest way to see what happens. If after having been off your TKI for a few days, everything's got better, that's quite reassuring. If the patient's unwell, we would definitely think about going in with steroids early because we don't want this to deteriorate into a worse situation. And again, involving our ologist colleagues can be really helpful in these difficult cases. So having things like the results of a FlexiSig, the results of a biopsy, some serial fecal calprotectins can give you a lot more information as to whether this is an IO colitis or a TKI diarrhea that we could give some loperamide to. There are lots of future opportunities here. I think this is an area where we've got a lot to do. We need to have a much better understanding of who gets toxicity and why. We've spoken about genomic and transcriptomic predictions for the patients who might relapse after surgery or why some patients perhaps should have more aggressive upfront treatment. But we also need that level of data for who's going to get these nasty toxicities and why that happens. We need an evidence base for the management of toxicity and having steroid-sparing approaches, going in with infliximab early perhaps. We don't have data to support this yet. Really importantly, we need real-world data about the toxicity that matters to our patients, and I think we've heard today that we probably are getting this a bit wrong at the moment, and we need some more data about that. There are absolutely possibilities of also giving these regimens in a slightly different way, so whether we could have treatment holidays, think about treatment de-escalation, understanding when it might be safe to stop treatment and those all-important treatment-free times. I think we know that there are other triplet therapies on the horizon and quadruple therapy in the future, who knows? I think we need to get this side of it right to enable us to explore more aggressive options. So my take-home messages would be to have a high index of suspicion for checkpoint toxicity and always monitor our patients' progress really carefully when you're treating somebody for a checkpoint inhibitor toxicity. And I think education of our patients and the wider group of healthcare professionals is also hugely important, and us getting data from them about actually what are the toxicities that matter to them. Thank you.
I think it's now time to wrap it up, isn't it? And I think, Lisa, you have this great opportunity to really bring all together all the different aspects of medical treatment. So, Lisa, how do you do?
Thank you, Victor. So my task is to try and contextualize some of that into real life, and that is the learning objective. We've had a lot of data about what happens in clinical trials, and then on Monday, you're back in your clinics, facing patients. How do you use this? And I'm going to, I guess my wraparound to that is there are many scenarios where I personally genuinely believe we have options and there isn't a wrong answer. What I'm partly going to do is pick out some of the situations where I think there is an answer that I think might be the better one in that situation, all else being equal. And then there are many others, and I can think of ways of manipulating my scenarios where I would be far less confident than I'm perhaps going to be in what I'm going to show you. So I'm just going to run through some quick cases. We don't have interactive voting, so when I'm saying what would you do, that's like you thinking there, what would you do? The first one is to demonstrate, perhaps to all of you, for you to yourselves and to me, that I have been listening during the course of today. And this is a patient I first met a few years back, a 46-year-old man. He was fit, active, well, no past medical history, no more comorbidities. And he'd presented with loin pain. He had a nephrectomy with what was a grade 4 PT3A N1 non-metastatic clear cell renal cell carcinoma with sarcomatoid features. The imaging you can see there. He was referred through to me for a consideration and a discussion, and he was unwell. And you'll see this is a month later, so really very quickly. And you all sit in clinics with patients. He walked in, he looked like an unwell man, and over the course of the next 10 days, when I saw him again, he was looking more unwell. So he was deteriorating quickly, and imaging showed that he had metastatic disease very rapidly. He had clustered supraclavicular fossa lymph nodes, mediastinal lymph nodes, a couple of small liver metastases. Bloods were actually fine, completely fine, so this made him intermediate risk. And I had to go through what are the options and what are the thoughts here. So I draw your attention back to the fact this is 2019, so it's a few years back now. We had IO and IO-TKI options. And so for me, these are the potential options we might consider. Triplet was not an option at this point in time. There were no data, and not an option, not licensed in the UK. And I guess these are my thoughts. This is a fit young guy, no comorbidities. He has sarcomatoid features. He has rapid recurrence. None of this, and obviously we'll get into this in a future case, is critical sites of disease where I am especially worried about further growth. What I want is response, and I want durable response, and I want him to have immediate treatment. So for me, this was a very classical patient where I was going to choose Nivo-Ipi, and it felt to me there was no other better option. Now, if I had worked in a healthcare environment where I had IO-TKI available and I didn't have IO available, sure, I'd have chosen an IO-TKI option. But I had IO, and for me, it's absolutely classical patient. And I'm happy to say that he's one of the fortunate people in the tail on the curve who has a maintained CR up until his last scan of a couple of months ago. And so for me, that's an illustrative there of the sort of patient I almost wouldn't think that's a sort of reflex reaction for me, as he would have Nivo-Ipi, certainly in 2019. So this is a different sort of a case. This is a patient, I met her just a couple of months ago. She was a 62-year-old shopkeeper, and I say that because she had a very active job. She was very active at work, had been until a couple of months before I met her. She had a history of pretty well-controlled type 2 diabetes, but not really anything else. She'd presented with upper back pain, weight loss to her primary care physician. She'd been referred and had various investigations done. By the time I met her, she had a reduction in her performance status, ECOG performance status 2. She had a renal mass, and she had multiple fairly widespread metastases, which you can see there. So she had spinal disease, she had multiple lung metastases, primary in situ, she was anemic. Her biopsy showed grade 3. Now, bearing in mind all we've heard today about how a biopsy could undercapture, may not be wholly representative, but the biopsy she had was a grade 3 clear cell RCC, and so she had poor risk disease. So here are my thoughts about this. Various options. Short history of deteriorating performance status and progressing symptoms. No significant comorbidities, but she was becoming frail, and becoming frail quite quickly. I think with significant spinal disease, you do always have to ask the question, is that spine unstable, and is there a risk in not operating? As a medical oncologist, it's a really important consideration. Actually, she did not have any spinal cord compression. She didn't have disease within the vertebral canal. And of course, a concern about stabilization without those particularly concerning features might lead to missing time delaying time to systemic therapy. So after considering that, she was going straight to systemic therapy. Now, I actually think this is a little bit more uncertain. I think you could argue this different ways. I mean, for example, you might have an argument about triplet therapy if it were available here. You might have an argument about IO, but she is one of the people in whom I was keen to get a response. And so for me, this was somebody where we did go to IO-TKI. And that was a choice she had. She's early in treatment. She's doing okay. I can't say, like the last case, that we clearly made a good choice for her. I don't know that at the moment. But that was the choice we made based on the features that I've shown you there, the desire to get her straight onto treatment, not miss a therapeutic window. She's this sort of, she could be a one-shot patient. People talk about the one-shot patient. The worry, if she doesn't do well quickly, she could progress further and may not get to second line. And actually, in thinking about Mike's talk, I think the illustrative thing for me there is I also treat melanoma. I think the DreamSeq trial has been incredibly useful in telling us that usually ipi-nivo is the frontline way to go. But even in treating melanoma, there are patients who we deliberately choose MEK, BRAF targeted therapy as the upfront treatment, so dabrafenib, trametinib, encobini, because you need to get a rapid response. So even faced with certain data, level 1 data about the benefit of combination IO-IO, there are still times when that's not the upfront choice because of the initial benefit for targeted therapy. And for me, she is probably in that category. And here are some other cases. So this is making the same point. There are cases when you want rapid response. So case 3, this is a 51-year-old woman, and what she has is a horrible base of skull metastasis. Her original nephrectomy had been in Hong Kong a few years earlier, and then she'd actually, in the meanwhile, as a young woman, unfortunately, had also had a papillary thyroid cancer, for which she'd been treated. She was on thyroxine for TSH suppression and doing well, and then she presented in the UK with tongue deviation with this horrible site of disease that I may have circled there, really, really nasty. She had radiotherapy through the neuro-oncology team, and actually that was her only site of disease, but biopsy had confirmed that this was renal cell carcinoma. Actually, because she's had radiotherapy, we didn't treat her immediately with systemic therapy. But when she relapsed, we did. And this is a really challenging site of disease. And I certainly was concerned about even the smallest amount of pseudo-progression here and the symptoms that that could lead to. So again, I thought about IO-TKI. I think any regimen with an OS advantage is reasonable. I don't think that's the only thing that's appropriate to consider here. And then we discovered the patient had Crohn's disease. Now, you might say, how did you discover a patient had Crohn's disease? So I think this is one of those mea culpa moments. We didn't have good enough history on her. Part of the reason for that was actually she didn't speak English, and we did all of her consultations through a translator. And it turned out we had never taken a good enough history, and we'd missed it. So, we missed it. That's not great, when you're thinking about patients. Now, once we knew that, this is pretty significant Crohn's disease. For me, Crohn's disease and IBD is definitely not a contraindication to doublet checkpoint inhibitor therapy, but it is a reason for a careful discussion of pros and cons, and so this is what we had. And in the end, it was her choice, and actually what we went with cabo mono. I don't think that's the only option that's appropriate for disease control here, but that was the patient-led once we were able to have a careful conversation with her. And that's what we did. So my last case is a 43-year-old man who I've got to know pretty recently. And he, in January of this year, had a radical nephrectomy for a massive tumor with sarcomatoid features. I was having a discussion with him about whether or not he'd have adjuvant therapy. He clearly met the criteria for consideration of adjuvant therapy. He had his first scan. It was a few weeks later. And he had a really large recurrence in just a matter of weeks. He had multiple bilateral pulmonary metastases. I had poor risk disease based on blood criteria. And so we needed to think about options for him. I think you could argue with yourself. I could argue with myself. Should he have IO-IO? Could he have IO-TKI? I really think there are arguments in either case. And in the place he was living, triplet therapy was not an option, so that was the debate that was being had. But I guess the point of this case for you is if I had triplet therapy available in my practice, this is the sort of patient I'd be thinking, yeah, he's fit, he wants everything, he wants long-term control, he needs something that's also going to work right now. So if I did have triplet therapy available, he is the sort of patient where I'd be thinking about using triplet therapy. Oh my goodness, this case was supposed to be deleted because I knew I had too many, so bear with me, and we'll go straight to take-home messages. I'm so sorry. So my take-home messages are, of course, we always think about efficacy. You have to think about specific toxicities and comorbidities, and very importantly, patient wishes, so you end up on the right decision together for your patient. There are arguments in favor of each of these in my case, but I think we are fortunate that we have these increasing options with, admittedly varying availability around the room. There isn't always a single right answer, and I think it's being aware of what your options are, specific pros and cons to each, and then having a careful consideration and discussion with your patient. Thank you very much.
Yeah, thank you, Lisa. I think it's a very good wrap-up, and really with really fantastic cases that are really coming from real life and not from clinical trials. So you're welcome to really join us at the microphones. Yeah, Michael. So we wait for you.
Lisa, just this last case, as a surgeon, he has a localized disease. You would think, that's easy, I can take that out. Simple like that. But this tumor doesn't look easy at all, Tim, right? It doesn't look like kidney cancer. It looks like something different. It looks like some disease that's going to be nasty, that's going to be progressive quickly on. I would not do surgery in him without a biopsy. And that biopsy then would tell me he has sarcomatoid and maybe rhabdoid and whatever. And I don't believe that those patients actually benefit from surgery, because surgery is going to suppress their immune competence for half a year, which is the time that you need to actually suppress the tumor and the tumor growth. So for me, that would be a candidate for upfront ipi-nivo in this setting, and not surgery right there. And I think we need to do a better job here in those rare cases where we have these adverse histologies that we can estimate on the scans or guess that they might be like that in this setting. And I would really like to make a strong case against surgery in those adverse histologies, because I don't think
So,
patients
Michael, I
benefit from
couldn't
that.
agree with you more. And
Don't.
No, I will. I mean, so it's always slightly painful agreeing with Michael, but I do occasionally. It hurts a little bit. I do agree with Michael, and maybe, hands up the speed with which I presented that case. So when he had surgery, he had localized disease. He had no evidence of metastatic disease on imaging within a fortnight of that surgery. It's been the most aggressively behaving case of, and that pathology has been multiply reviewed in at least 3 different countries in good pathology departments, and the consensus, and actually the robust consensus across the 3, is this is sarcomatoid renal cell carcinoma. There was a consideration, was it primary sarcoma, and it did have that horrible infiltrative picture that I think we saw in one of Mike's talks earlier on today. But so in the 15 years I've been a consultant, it's been the most aggressive case of renal cancer I have seen.
We actually, with Nizar, we have this on RMC where we're like, if we have those tumors centrally located that don't really look like clear cell cancer or something clear, we should do a biopsy and maybe restrain from surgery and put them to systemic therapy first. Maybe we should think about having a consensus paper on really aggressive sarcomatoid and rhabdoid cancers in a localized situation as well.
If I could add, we've certainly seen these types of cases, to your point, where post-op the disease it just explodes, very similar to Lisa's case. And I agree. And it really highlights to me the fact that we need to work together as surgeons and medical oncologists, and early on think about patients who might be candidates for perioperative therapy.
And I would add, the debate is over, but in my Gary Larson cartoon, I would add this category of patients with their primary in place, where it's better to start with an immune therapy, because you can do surgery in the middle of that treatment without stopping the treatment while you have to stop the TKI for 4 to 6 weeks, and that can create some problems.
Dan? Was it, or,
Yes,
or Dina? Sorry.
I don't know.
I'll of course let Dan go first.
I can yell really loud. Sorry. So I saw several posters of real-world evidence that suggests the results in the real world for patients getting all of these regimens is much worse than what we see in the clinical trial setting. So, and I think Lisa did a great job of really showing us, examples of the challenges that we have in the real world setting. And those are just cases, but we all have many of these, and our colleagues in the community struggle maybe even more so with the resources that we have. So help us understand, which of your regimens do you think, Tian and Michael and Lorenz, translates best into the real world setting of community practice, and what are the things we're missing to make these regimens more effective in a broad patient population?
I think we have to be careful about drug exposure, and this is true both on the CTLA-4 side as well as the TKI side. Maybe what's happening is because of challenges in managing toxicity, or even being afraid of toxicity, it may happen that those treatment schedule are not being respected. And I think this is something we need to work on clearly, because we need our patient to be properly exposed to the agents we have. And this is true both for ipilimumab as well as for our VEGF TKIs. That could be part of the explanation.
I certainly think that managing the toxicities and having what Kate highlighted, 24-hour access and resources for anybody seeing the patient, even in the middle of the night, to manage appropriately and start steroids quickly if they're having very severe, life-threatening toxicities is important, and that may get them through the hump. So we have seen early on in pedigree that in ipi-nivo treated patients, it's very difficult to get them through 4 cycles. So in order to increase that dose density and get patients through the toxicities, having more resources would certainly be helpful.
Yeah, so I think that the message is wrong. We don't need to give 4 cycles of nivo-ipi. We just need to treat till their immune system is activated. If their immune system is activated, we've done the job. And then we can, when they're ready, switch to maintenance. And so it bothers me when people say, I can't get all their treatment in. That is not the issue. You've done your job when the immune system is activated, and there must be some other reason why people are worried about missing those doses, because the patients already got their treatment.
I think it's a good point, and I do think rather than everything going towards triplets, we do need to think about sort of what's the minimum amount of treatment we need to get patients, and then what do you do with the patients that can't maintain those maximum tolerated doses? Is there alternative approaches to managing those patients in that kind of adaptive design? So you do a lot of adaptive design, Cian, and I think they're really wonderful, and I think we need to think of them in terms of the patients that struggle with tolerance as well. But no, it's great discussion.
Dina.
I hope this is working. Oh, there we go. So everybody mentioned the fact that patient preference should be part of the selection process, and I really appreciate that. But to Mike's point, if you don't get ipi-nivo up front, then you really don't have that as a therapy option in the second line, whereas you would potentially have IO-TKI in subsequent lines. And I would just wonder, is there an obligation to tell patients that prior to starting first-line therapy so that they have an opportunity to consider whether they want to take the risk of doing IO up front, even if they don't meet the IMPC criteria?
Short answers, please, because we're going to run out of time soon.
I think that's always important to inform your patients of everything, including now that IO-TKI doesn't work in the second line, as we know from the CONTACT-3 trial.
And we don't have access to that anyway.
I think the short answer is yes. So Samra, can we have short questions and answers so we can try and get through the remaining 3
amazing
if we're
session.
allowed?
Congratulations to you all. Isn't the fundamental issue here, which probably relates to melanoma as well, is our lack of understanding of what CTLA-4 is doing? So the question is, how do we as a community resolve this? And also, how do we compel pharma to let us interrogate this question, even though, IPI's no longer that relevant? from a commercial perspective, in all the work and the investment of patients and clinicians to date?
So there might be several answers to that, Samra. Thank you for your great question. First, we're all waiting from the 8Y8 study, which is the EMA-requested study when the 214 read out, which is nivolumab plus ipilimumab versus nivolumab. This study hasn't read out yet, and of course that will help to see the added value of ipilimumab that all of us see in clinic. But to your point, I think the question, and also to Mike's comment on what we want is to trigger the immune response, is how we build our translational work around those trials. And so we do need to do a better job with regard to analyzing those prospective studies so that we can ultimately have the biomarker piece that is missing and that you're working on. Thank you.
Okay, so wonderful. So we do have 2 more questions. So Nisa, I don't see you, but I know you're there. You have a question.
This is a great session. I really enjoyed the debate, but I would like to, for Gabby and Michael, the co-chairs of this conference, for a debate like this, lively and very, very interesting, I wish we had audience participation from the beginning with, get the opinion before the debate starts, which first line you pick for, your patients. And then after the debate, okay, did you change your mind based on what you heard? I think this will be hopefully for next year. But I'd like to appreciate the idea of having a triplet in the debate, but it is, in my opinion, not in the debate. It should not be in the debate. You can argue, the idea of we want to improve on doublets. Of course, in the context of a clinical trial, the patient should be considered for a triplet, but right now it's not in the debate. I think when we think of adding a TKI to immune checkpoint inhibitors, the patients who really deserve it the most, we talked about, Lisa mentioned about one shot at goal. It looks like the triplet actually for poor risk did not benefit those patients that really needed that one shot at goal. And so for intermediate patients, most intermediate risk patients, I think I can get them through an IO like as Michael articulated, and then those who didn't respond, they can go to second line safely. So I hope in the future we will not have that debate because we will know from biomarkers which patients will likely respond or not at all respond. And I wish I knew which patients will not really respond to nivo-ipi, and those patients should be spare the toxicity, and then they should be treated with something else. I think this is really what the field should move to. It behooves us to work on biomarkers to predict before we decide what treatment to give. Here is your biomarker signature. You should go to nivo-ipi, not just sarcomatoid, which obviously we know this is one clinical biomarkers, but also which one really best be treated with whatever therapy we give them. Thank you.
Thank you, Nizar. I'll pay you afterwards.
And Nizar, I would just add, though, that your points are really well taken. And I think as a kidney cancer field, we're behind our melanoma, lung cancer, breast cancer colleagues in how we find those right patients for the right treatment. And certainly in an era where we're in precision oncology and thinking about molecular selection, those types of studies, smarter studies of patient-selected populations are much needed. I agree.
Yeah, I think the Bionic trial tried to do this. Brian Rini is launching a trial, phase 2, also trying to implement those signature in the way we select our treatment. What we need to do now is proceed to larger trials and ultimately be able to change the guidelines based on a biomarker. This is what CARE1 is trying to do.
Yeah, I think, it's a very good summary how diverse the biomarkers are, but I think the one biomarker that we use already, and we all agreed on during the talk here, during the session, is sarcomatoid. Sarcomatoid features are really immune responsive, and I think that came up as a theme in all of the cases and presentations.
So we're delighted the session's generated so many questions. We will have one more, we're over. But Tim?
Shall I ask?
Yeah.
No, you may ask.
Quick question. Is there any evidence of regimens being different with the kidney in situ? There's a best regimen for kidney in situ, best regimen when kidney isn't in situ, or is that data not there?
So there has been analysis, and we touched on that this morning, I believe, looking at the subset of patients that had or had not prior nephrectomy. And I think Arnaud Méjean showed that the magnitude of benefit seems to be pretty much the same, irrespective of prior or no prior nephrectomy. Am I answering your question there?
Yeah, do you choose, I suppose, do any of you choose a different regimen because there's a kidney in situ? Or
No, I would say no.
And my comment is it was an amazing session, certainly here. I think the sweet spot on neoadjuvant is biopsy sarcoma and then randomized. I think that is the sweet spot. And Dr. Atkins, that was forensic. An amazing talk. I really, really enjoyed it. It was amazing. Thank you.
So thank you very much.